So today's class topic is case presentation on endocarditis, and our moderators are Dr. ARIF PASSA, who is Professor and HOD Depth of Critical Care Medicine in NRI Super Speciality Hospital, Andhra Pradesh. And then we have Dr. SWARNA DEEPAK Kumar, who is Senior Consultant in Internal Medicine and Critical Care Medicine in Apollo Hospital, Jubilee Hills. And here we have Dr. B. Suresh B., who is resident in critical care at NRI Medical College, Guntur, Andhra Pradesh. He'll be our presenter. And I would like to thank our organizers, who is Dr. Akhilesh Tandekar, Dr. Gunadhar Padi, and Dr. Asif Iqbal. Thank you. Sir, you may start the lecture.
Thank you, Sana. I think Arif sir, will be waiting for Arif sir. In the meanwhile, I think thank you for the opportunity. And
yes, sir.
Yes, sir. Arif sir.
Thank you, Sana, for the kind introduction. And we thank the organizers from the Farz Academy.
A very good evening, my mentor Arif sir and SWARNA DEEPAK sir and all my colleagues. So today we'll start with a case presentation. So
Yes.
A 62-year-old man, known case of type 2 diabetic, smoker, native of Vijayawada. He came to our ER with chief complaints of fever with malaise since 1 week, shortness of breath since 1 week, altered sensorium since 3 days, and bilateral lower limb swelling since 3 days. So these are the chief complaints which the patient presented to us, our ER.
Yeah. So, Dr. Suresh, can
Sir.
we hold here? Yeah. With these history findings, like a 62 years elderly gentleman who is a diabetic smoker, so presented to you with fever, shortness of breath, altered sensorium. At this junction, what are your differentials in your mind?
Yes, sir. So the patient presented with fever, SOB. So it could be any tropical infections involving the lung, and also having altered sensorium. So it could be meningoencephalitis. Bilateral lower limb swellings are also there. So could be any heart failure features or any complicated malaria like this, sir.
Why do you think of
Is it
complicated malaria here?
The patient is having altered sensorium, fever present, any tropical infections.
So I think the Arif sir, what both of us were trying to ask the student here is, each of this, you need to have a background as well as the chief complaint. Right? In this slide, you are showing both of them. What does this line of 62-year-old gentleman, diabetic and smoker, as well as the nativity of the patient, right? Each of them has a significance of its own. The age of the patient makes you the vulnerability of the particular patient, right? Extremes of age group, obviously, they are vulnerable.
7.3
Yeah. Sana, kindly unmute them. Yeah, kindly mute them, Sana.
Yes.
Mute all.
Yes.
Yes, please.
So that is how we're saying diabetes as per se is not enough. Okay. So you need to state, is it a controlled diabetes or is it an uncontrolled diabetes? What is the background of it, right? For example, each of them, I think as you present, will improvise it, but the background, the comorbidities of the patient has a lot of bearing on the expected diagnosis as well as the severity of the diagnosis. Smoker, as you again said, I think we expect you to elaborate the smoking history in the further down. Okay. If you're an IDCCM exam, maybe it will be quite brief. But if you're a DRNB or DMA student, we expect you to be better in elaborating the history here. Again, the Vijayawada or for that matter, Hyderabad, whatever it is, each of the locality has particular diagnosis. You may have a flu outbreak here. You may have a different mycoplasma outbreak. So each of them, the nativity of the patient, you need to be aware of the diagnosis in particular to that patient. Coming to the chief complaint, each of the complaint we expect you to elaborate as the history, you present the history. For example, fever with malaise. you need to have something in your mind. Is it a high-grade fever, intermittent fever? Is this paroxysmal fever? Where is it the fever in the
Yeah.
evenings, in the mornings? Okay.
Are
All
you
of them
going to elaborate in the next slides, Dr.
Yes, sir.
Suresh?
It's
Ah.
present
Are you
history.
going to
Yes.
elaborate?
Yes, sir.
You are supposed to elaborate, and in this single slide, each of them, before you elaborate, you need to have something in your mind as per the differential diagnosis, right?
Yes.
Yes.
So
Yes.
go ahead. I think go ahead. We'll complete again. We'll come and move forward. And
Sure.
yeah.
Yes. So coming to the present history, fever is high grade, 1 or 2 degree Fahrenheit, continuous, not relieved with medication, associated with chills, and then no diurnal variation. Shortness of breath since 1 week, progressive, increased since 4 hours before the admission, associated with dry cough. And altered sensorium was also there since 3 days, and bilateral lower limb swelling 3 days, fitting type. And he had history of hospitalization 10 days ago for the urosepsis, for which central line venous catheterization was needed in that hospitalization period.
So I think you're going a bit too fast for us. So can you elaborate the fever? What do you mean by high grade fever? What is high grade fever, mild fever, and low grade fever?
Sir, up to 100 degree Fahrenheit, it's low grade. More than 1 or 2, high grade.
So it basically depends on the classification which you're using. Okay.
Okay, sir.
What classification are you using? The usual classification what we use is a simple one where it is less than 99, okay? Or maybe less than 100. 99 to 100 is called as low grade. That is 100 to 102 is called as moderate. When it is more than that is called as high grade. Is it important for you when you are doing this?
Based on this mild, moderate, severity, severe grade, the causative organ, the cause may be different.
Can you just elaborate in a point? See, ultimately, end of the day, everything revolves around your diagnosis, isn't it?
Yes.
To use this thing to point towards some construction of the diagnosis at the end of the presentation. So here you are seeing it's a high grade fever. Definitely, whatever the pathology which is underlying is a significant one, right? It's been continuous and high grade, whatever it is. It may be a significant one. And the point you are very clearly stating is not relieved with the medication. Which medication are you talking here?
Sir,
What is the medication with which it is not being relieved?
paracetamol, sir.
Okay. So you need to state it here that it is not coming down with the paracetamol. Okay. What does the chills mean? Chills. Chills. No. What does the chills indicate here? Usually, chills indicate that there is some bug which is coming as a shower. Okay. Right. You might have seen it, right? In the malaria there will be chills. In a urosepsis there will be chills. So basically tells you that there's a shower of the bacteria or whatever the pathogen. It is coming as a shower in the blood. So that basically tells you that there is something present in the blood. Usually that is the which we know. So something is there, and there is no diurnal variation. Diurnal variation where what are the fevers where you know you'll have a diurnal variation?
In case of UTI and tuberculosis.
UTI, why there will be diurnal variation?
Okay, sir. Tuberculosis, malaria, no, tuberculosis, evening rise of temperature.
Okay. So then for that one, you need to know what is the normal variation of the temperature, isn't it?
Okay, sir.
What is the usual variation of the temperature? Sorry, I thought I'll start it.
No issues. No issues. Please go ahead. Please go ahead, Dr. Deepak.
So what is the regular diurnal variation expected? Is it high in the morning or is it high in the evening? Usually.
In the morning.
Usually it will be lower in the morning. Okay. Usually it will be higher in the evening. That is how most of the fevers behave. Okay. Even
Okay.
even the usual diurnal variation is it usually fluctuates by a degree of 1 degree, usually most of the individuals. So you need to accept that. But also you need to know here the regular variations of the fever. In olden days, you know, no, in the tuberculosis, lot of fevers will have a regular dilation. Most of them comes in the evening. It is basically an exacerbation of the regular pattern of high diurnal temperature in the evening. In this particular
Yes.
fever, you will be having a bit more in the evenings. It will be exacerbated. So here there is no diurnal variation. What does that tell you? It tells you what are the bug which is there in the blood. It is being there continuously throughout the day, and it's been there throughout the week also here. That is what it tells you. It is something which is significant here. Okay. When you're
Yes.
understanding a fever, you need to understand in a totality.
Okay.
Understood? So then
Yes.
you coming to the second point, you said there's a shortness of breath. So elaborate properly. What do you think here is happening?
Yes, sir. Shortness of breath since 1 week. It is insidious in onset, progressive.
What is insidious and what is sudden? What do you understand? Here you
So
haven't stated.
yes, sir. Yes, sir. So insidious means uh, it will progress over the day, but sudden means it will start suddenly within 1 hour. It may progress to grade 4 SOB, shortness of breath.
Okay.
So the DDs will be different for insidious and insidious onset and sudden onset. So in case of sudden onset, it could be pneumothorax or pulmonary embolism, like that. The differences will be like that. In case of
Okay, complete fastly.
sir, in case of insidious onset, uh, any pneumonia case progressing or like that.
I think you have been quite non-specific.
Sir, mute.
Sorry, I think see the classification should always be in the numbers and objective. Okay. So when
Okay.
you classify anything, is it in minutes or is it in hours or is it in days? Okay. Here you are saying if it's in minutes or in hours, usually we are talking about something very acute condition. Usually acute shortness of breath, something vascular or pleural. Pneumonias and those kind of infective pathogens, they don't come in a period of time. Isn't it? Here you are saying something which has been slowly building up for a period of a week. Here definitely we are not talking something, okay, acute pneumothorax or pulmonary embolism. If you're talking about it, it's kind of shower of emboli which are occurring over a period of time, not something which is massive embolism. I think students have been complaining that the voice is not clear, but am I clear to you, Suresh?
Sometimes it is breaking, sir.
From my side, it's clear. So whatever the cause you are talking here, it has been building up over a period of a week. And this
Yes.
last line, which you are saying, that is the increase in 4 hours, which is
Yes.
something you need to keep in mind.
Yes, sir.
Okay, that tells you whatever the thing which is happening, it has suddenly increased in the complication. Okay.
Yes.
So till here, something which is related to the fever and the lung, which is happening here. Okay.
Yes. Yes.
From there, suddenly you said there's an altered sensorium. What do you mean by altered sensorium here?
Altered sensor patient was patient attendants told that the patient was drowsy and was uh, not able to convey properly. Means
Here you need to remember that the consciousness is different from the sensorium. Okay.
okay, sir.
Consciousness is a function of your cortical function. That is, patient is becoming drowsy. You have those phases, no stupor, comatose, all those things. They are cortical functions. The sensory is a function of that is a kind of behavioral function, like the person who has like the place, person orientation, or there will be sudden aggressiveness of the patient, sudden kind of dullness. These are all called as altered sensory. Okay? So both may be together or both may not be related also. So you need to be very clear what is happening here since 3 days. Okay? So for a critical care exam may not be too deep, but I think we expect it at the DM level or DNP, DRP level that we need to understand the difference between both of them. So whatever it is, there's a dip in there's a change in the sensory. That means the brain is also getting it. Okay? So when you're
Voice is breaking.
my voice is breaking, I think. Then I'll give Arif sir maybe. I don't know. I'll just try to refresh it. I'll come back, log in again. Arif sir, can you?
అదే సార్ కొంచెం మానిటర్ ఫ్రంట్కి వస్తే బాగానే వచ్చు మానిటర్.
Oh, then okay. Then I'll just come a bit nearer. Okay.
Yes.
Is it okay? Is it okay now?
Yeah,
Yes,
yeah.
sir.
Please proceed.
So altered sensorium is a very important thing here. You need to be very clear what you're talking about. Okay. Along with
Yes.
it, is it something which has been there in the past or is something new? Is it associated with the focal neurological symptom? Like if is it associated with some seizure? Is it associated with some kind of motor deficit or sensory deficit? All those things. Okay. Okay, then you suddenly came down to the lower limb swelling. I think it is somewhere you are not fitting the history, but it may be important. What do you mean by lower limb swelling here 3 days?
Yes, sir. Since 3 days after SOB has started, the patient attendants has told that the patient is also having this lower limb swelling, which is of pitting type.
Are they equal both sides here?
Yes, sir.
Okay, fair enough.
Yes.
Is it started from distal to proximal or proximal to distal?
Distal to proximal.
Okay, quickly you can elaborate it. We'll again see. I think I'll just finish off this slide and give it to Arif sir. So last
Yes.
one was he had an hospitalization of 10 days ago for urosepsis. For which central line, is it? Why do you suddenly brought this up? You had some diagnosis in your mind, right? You're building up your diagnosis, right? So this usually you can keep it, but it should be relevant to it. So why do you think this is important here?
So the central line catheterization.
Why do you think it is important here? One is definitely fever. I understand you're thinking about
Yes.
some nosocomial infections, isn't it?
Yes, sir.
Okay. So summarize your present history. Just what is the diagnosis you're thinking in your mind?
So the patient, the 62-year-old male, diabetic smoker, so having this high-grade fever, SOB, since 1 week, and altered sensorium and bilateral lower limb swelling 3 days, sir.
What is the diagnosis here? Just tell us 3 differential diagnoses.
Sir, could be tropical fevers causing encephalopathy features.
This patient, Suresh, this patient was already hospitalized 10 days back.
Yes, sir.
Okay. You already said there is something with the lines and those kind of stuff.
Yes,
Already
yes, sir.
elderly gentleman with a diabetic history, right?
Yes,
and the fever already we have seen that it has been continuous and there's a chills.
Yes.
So
Yes, sir.
here the first differential diagnosis usually what we need to think is there's a urosepsis. Urosepsis also has a part of chills, continuous fever. He was admitted.
Yes.
There may be a complication of the there may be a recurrent urosepsis or the urosepsis which started as a simple one must have got complicated. Okay, that MC matters, those kind of stuff. That is the first differential usually. And because it's in the kidney, you can have an AKA and there may be preparation of the shortness of breath. I started initially as slow one, slowly building up, we may be in an AKA. That is the usual first differential diagnosis, isn't it? It's fitting everywhere. And the uremia can cause an altered sensorium.
Yes, sir.
Isn't it? That is the first one
Yes.
usually we'll keep. And the central line, obviously, you can have an infection. Maybe that kind of complicated it. That is the second one, right? Third one may not be related to this background one, right? Tropical
Yes.
fevers usually comes in the maybe a bit later on in the priorities here for me.
Yes.
Arif sir, please take over, sir. Yeah.
Yeah. Please, yeah, go ahead, Dr. Suresh. So our possibilities, sir, one is urosepsis, maybe possibility going into complicated UTI, Possibly pyelonephritis. Yes. The second one is? Yes, Dr. Suresh.
Yes,
Is
sir.
it audible?
Yes, sir. Yes, sir. So as the
Yeah.
so for the urosepsis, the patient was central line catheterization was done previously. So
Okay.
infection possibility is there, sepsis possibility is there, sir.
Yeah. Yeah.
So
So how are you going to explain this altered sensorium?
altered sensorium in this case could be due to septic encephalopathy, sir, urosepsis
Okay.
or uremic encephalopathy.
Okay. So later on, you're going to talk about this, how is the sugars and all that. Okay. Okay.
Yes.
So one is urosepsis complicating, the possibly the shortness of breath and all.
Could be due to lung septic cardiomyopathy or myocarditis.
Possibly added on with
Have-
lower limb
uh,
edema and all that, maybe in the failure patient,
yes,
maybe.
yes, sir.
Okay. So
Patient may
move
be
on,
in
please.
pain.
Move on. Yeah.
Yes.
Yeah. 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 Move on.
So,
So
Suresh, just to as a tip to the students, for each of the complaint, you have three differential diagnoses for that complaint. And
yes,
at
sir.
the end of that one, try to mix it and see if they're fitting into three differential diagnoses, right?
Okay, sir.
You understood what I'm trying to drive it?
Dr. Suresh and Dr. Deepak, I just have a comment. It's like very good, well presented. So what Dr. Deepak told is absolutely right. So whenever you are presenting a case, you summarize the history very nicely, and of course, Dr. Deepak has dissected it very well. When you present, sometimes the examiner just want to listen the only the salient the differential diagnosis.
Features.
So in
Yeah.
that case, yeah, you should have something like in your mind systemic wise, or you can have a broad idea
Positive
like
points.
whether it is a urosepsis, meningoencephalitis, myocarditis, septic cardio, or your septic encephalitis or tropical fever. So that he can jump quickly into your you say the differential diagnosis and the working management. Yeah, I think well presented. I think yes.
Yeah. Please proceed.
Yes.
Yeah. Move on.
So past history, the patient is diabetic since 10 years on oral hypoglycemic agents. So personal history, he was married with 2 children, taking mixed diet. He was smoker, occasional alcoholic, and there is no recent travel history.
Suresh,
And he was
how much was the HbA1c of this patient?
HbA1c, sir, 7.5, sir.
7.5 is not too bad. Slightly above.
Yes.
Usually, the medical reasons we classify as it less than 7 or more than 7. Less than 7 is reasonably well controlled, but it's not that bad. Okay. And here,
Yes.
metformin is there because he had already had a urosepsis. You're thinking about an AKI. So metformin can cause your lactic acidosis. You know what I'm talking about, right? So this is
Yes.
medical history. You need to be a bit careful. Okay.
Yes, sir. So this is the history, sir.
So what is the diagnosis? History is over.
So
Yeah.
So only thing we know is he had some sort of infection which is going on, seems to be quite significant because he has already become breathless and has already history of hospitalization. Thinking about the possible sources of lung or urinary tract. This is what that is saying.
yes, sir.
Yeah.
So as there is
move forward, Suresh. Move forward. Yeah.
yes, sir. So on
Yeah, yeah.
examination,
So what, Dr. Suresh, what is our
sir,
intention is at this junction, you should have few DDs where you have to go on with the narrowing that DDs. Okay.
yes,
Right. Please proceed.
yes, sir. So on examination is airway, in view of poor GCS and respiratory distress, the patient airway is secured. And coming to breathing part, saturation was so before securing saturation part 75% room air, respiratory rate of 38 per minute, and the bilateral area entry equal, and there are bilateral basal crepiations present.
But
The
you said bilateral air entry is equal, and again you're saying bilateral basal creps. No need to mention the bilateral air entry equal here. Okay? You can only mention the second findings here. Okay. Unnecessarily you are going into a different tangent. So breathing is bad. Is this off? This is before your intubation, right?
Yeah,
Yes.
before securing, it seems.
Okay, fine.
So coming to
Because
circulation
this
part,
is the examination part, no? There is no need of that airway securing at that moment. Okay.
yes,
And
yes,
Yes.
Suresh, you're talking about a lung diagnosis here. Is it by meaning of Krebs? Do you mean by bronchial breathing?
no, sir.
No. Oh, so then you're ruling out the pneumonia straight away.
Yes.
So you're thinking this is free fluid, right? Okay, go ahead.
Yes. Yes.
So coming to the circulation part, the BP is 80 or 60 m of Hg. The pulse is 142 per minute, and all peripheral pulses are felt. The disability, the sugars were 180 mg per deciliter. Pupils dilated normal size reacting to light. GCS was before intubation E2, V2, M5, and all four limbs moving. And there is a altered sensor. We have checked for neck stiffness. There is no neck stiffness, and Kennick's and Brzezinski's signs were negative, sir.
Here in the circulation part, you mentioned the BP. You need to mention the capillary refill time as well as the shock index also here. Okay, it would be a good practice for you.
Okay, sir. Yes.
So basically, his breathing is bad, and as well as his circulation also is bad. That's what you mean, right?
Yes. So an exposure, temperature is 101 degree Fahrenheit, and there are no any external injuries.
Why are you suddenly talking about exposure and external injuries? This is not a trauma patient.
Yes, sir, but
no, not required. Just keep it simple.
Yes.
Okay, you discuss about breathing circulation. Okay, go ahead.
Yes. So as the patient is in hypotension, after taking the ABG, we have secured 18 gauge 2 cannulas and started on with fluid resuscitation guardedly by doing focus. And
No, how did you do this? First of all, interpret this APG.
so it's metabolic acidosis with almost slight respiratory acidosis there, sir, with lactic acidosis, lactates for 6.
It's predominantly a metabolic component which you're dealing with. In this particular patient, he has 2-3 issues, right? Because he was short of breath. So
Yes.
it must be a respiratory one. If you leave it aside before seeing the ABG, you need to see the patient first. Okay. This is a
Yes,
patient who had a shortness of breath as well as suspected urosepsis and possible AKI with a
And the
metabolic.
patient is in shock. Yeah.
He is in shock. So
Yes.
you need to
Also,
first
yeah.
see, is it a metabolic component which is predominating or is it a respiratory one, right? And you
Yes,
already ruled out there is a pneumonia to start with basic auscultation part. So this patient's predominant problem you need to tackle with is this is after intubation or before?
Sir,
Is this ABG before or after intubation?
before, sir, before intubation.
This is before intubation. You said 74 saturation. PO2 is 164 here.
Yes, sir, but it is on O2 support, sir.
How
with,
much? What is your SF ratio? What is the conversion factor?
About 10 to 12 liters with O2 phase.
Sorry, you wanted to discuss infective endocarditis, unnecessarily I'm deviating.
Yeah.
So we have short of time.
No,
So
because every student should know. Yeah. How to go ahead. Yeah. Please.
So here they will definitely, your examiner will discuss about you the ABGs. Is it first point? Is it valid or not? From right from. Don't expect that they'll only discuss about your infective endocarditis. Okay.
Okay.
As well as I think they obviously discuss about the resuscitation part. Here you're thinking about a cardiac failure also initially, right? You said bilateral collapse.
Yes.
How did you resuscitate this patient with a focus? How did you make use of it?
So the purpose we see IVC variable, it's an inferior vena cava variability. If it is more than 1.7 to 1.8 centimeter and less than, if it is more than 50% variability, then we will go for fluid, sir. And we will also see the profile of the lungs, sir. Is it B profile or A profile? So if it is A profile,
Yeah,
we start.
is the focus finding is there here? Focus picture is there? The video?
Focus. I have written, sir. Only.
Okay, go
Okay.
ahead, go ahead, go ahead.
So
Go ahead.
one point here is IVC has a lot of fallacies and fallibilities. Okay. So especially with a patient, if you're conscious patient, they'll be having a lot of air hunger. The IVC can be collapsed. Okay. These trials on IVC were done in a stable patient when they're in a particular angle of 30 to 40 degrees. So you need to understand that this mere presence of collapse doesn't mean anything. Also, mere diameter doesn't mean anything. You need to see the chambers first, practically first, then come to the IVC. Rather than
Voice breaking.
usual tendency in the students is forget about the heart and just see the IVC, right? See the heart, see the chambers, see the outflow RVOT, LVOT, and then come to the IVC. Okay.
Focus.
Okay, you started vasopressor, not it. Okay. Okay. Then what did you do?
So on systemic examination, the patient was drowsy, arousable, sir. That means this is before intubation.
Drowsy, arousable. You said okay. Okay.
Not obeying verbal commands and moving all four limbs. The pupils were bilateral, normal size, reacting to light, and this is was E2, V2, M5, sir. After intubating the respiratory system, the patient was mechanical ventilatory support with FiO2 of 60%, the PEEP of 10 centimeters of water, and the bilateral chest movements were symmetrical and regular. There are bilateral basal crepitations present, sir, still. And cardiovascular, the apex beat in the left fifth intercostal space, middle to mid-clavicular line, S1, S2 are heard.
Oh, seriously, Suresh, such a sick patient, when you're intubating and keeping lens, you bother to see the apex beat also, and you locate it. Great, man. Here, I think you should elaborate. This is a critical care exam. No, elaborate more on your echo findings here. Okay. What was the finding on the 2D echo in this particular patient?
So the focus was.
You are not having that video? Yeah.
Yeah.
Yes.
So,
Okay, go ahead.
Focus was done, sir. Having bilateral B profile. IVC was 1.5 centimeter, and there are bilateral thin rim of pleural effusion. And in the four-chamber view, the contractility is fair enough, LV contractility, with having some small abnormal opacity like vegetation in the mitral wall leaflets.
So in an emergency situation and in this kind of sick situation, you've done an echo, okay? So you found something which is a bit abnormal, not fitting into regular one. You found some kind of doubtful vegetation, right?
Yes.
So what is the suspicion you are having in this patient?
So as there is in the focus, as there is a suspicion of vegetation, we are thinking of in line of infective endocarditis, along with the clinical history.
Okay, fair enough. Fair enough. So, so can you tell some points about 2D echo in endocarditis? What is the sensitivity of picking up endocarditis by echo? You're doing a transthoracic echo here, right?
Yes, sir.
So, what is the sensitivity of TTE for a native and prosthetic wall endocarditis?
TTE, it is about 60 to 70%, sir. And transesophageal, it is up to 90%, 99, 90 to 90.
Good. So you need to classify based on the, is it a native wall you're talking or prosthetic wall, right? Here you were talking about a native wall. This patient didn't have any valve operations or nothing, no mechanical devices, isn't it? So this patient usually it is up to 70% or sometimes more than that based on the machine, your probe, your window, lot of other factors. Okay. TTE is not inferior.
Yes.
But if for it is a prosthetic valve endocarditis, because there will be a lot of artifacts because of the valves, the usual sensitivity is only around 50% or less than that. Okay. So
yes,
TTE is not inferior. That is something you need to see. Also, one thing students need to remember is there may be a lot of false positivities about the vegetations also. Okay, so in a chronic patient, especially patients who had a center lines and this kind of stuff, no, you can have a thrombi, which also can be mistaken for the vegetation. And again, the image is very important. The good thing, and do you want to do the TTE here? Sorry, TEE, transesophageal echo here. What is your take? You identified something on the vegetation, the doubtful vegetation. Do you want to do a TEE or do you want to stay here?
So for the diagnosis, TT transthoracic is enough, sir. For if you want to know any complications, we have to go for transesophageal.
Okay. So the point is when you're suspecting a infective endocarditis, TTE is all very good. Okay, it's not inferior provided that you know what to see and you have a good machine. So everyone should get a baseline conspiratic echo. When are you? I think you rightly said. When are you going to get a TTE is when you have a significant suspicion, persistent suspicion. If your TTE is not that clear, that is sometime when you get a TTE, or sometimes TTE is positive, you have a very high risk features. What are the high risk features? Very large vegetations and freely mobile vegetations. There is an associated valvular regurgitation, or when you're suspecting an abscess or suggestion of a perivalvular extension, you have an LV failure. Or you have a background like a complex anatomical disease, like a congenital heart disease. Then you are trying to go for an early TE. If you don't have it, if you don't have these conditions, TTE is also good enough. And when are you going to repeat this? You noted this. You could think that you had a picture of this picture. When are you going to repeat the TTE again? When do you want to repeat the studio echo again? You're going to repeat when there's a deterioration of the patient.
Voice breaking.
I think the host is muting me repeatedly. You are going to repeat the serial echo when your patient is deteriorating clinically, or when you're suspecting a increased regurgitation, or when there's an extension of the perivalvular. That is the time when you repeat it. That is the advantage of transthoracic echo is you can repeat serially, whereas TEE is very difficult to repeatedly do, isn't it?
Yes.
So everyone, you need to know the findings on the 2D echo which you expect when in a infective endocarditis. Okay. Go ahead. But
So
why there's a B profile when your LV contractility is good? You had a doubt when you have a suspected infective endocarditis, and you're talking about left side endocarditis here, not the left sided, not the right sided. Both are different. Remember that right sided endocarditis are very difficult to know clinically. They will mimic, most of them mimic like a embolism or pneumonia, those kind of stuff. You're talking about left-sided endocarditis. Left-sided endocarditis, it's usually right-sided will get a septic emboli. They can lodge in the lungs. Whereas the right-sided usually manifests with a distal manifestation like a stroke, splenic infarct, those kind of stuff. Lung involvement here you need to explain, especially when you have a good LV contractility. Okay.
Yes.
Go ahead.
So this was the ECG taken having normal sinus rhythm.
So what are the things you'll expect in an ECG in these patients with a infective endocarditis? So again, it depends on are you talking about left-sided endocarditis or right-sided endocarditis? Isn't it?
Yes.
For a right-sided endocarditis, most of them you can have a conduction block. It can start from simple first degree to complete heart block. Okay? You can have a pericardial effusion. You can have anything in the ECGs. So again, ECG in an endocarditis is a very important thing.
Yes.
Pericarditis, anything can be there.
Yes.
Then?
And this was the chest X-ray showing increased bronchovascular markings and apparent cardiomegaly, sir.
Okay. So in an X-ray, what do you look for? What are the things that can be found in the X-ray? One is your classical thing, which you told is a pulmonary edema. Here
Yes, sir.
you need to explain to us why it is there, because your LV contractility is good. Okay. But having said that, in the X-ray, what are the things you need to see is one is pulmonary infarct. You can have a wet infarct. Second is you can have a septic emboli resulting in a pneumonia. Okay. Or you can have an associated infection, pneumonia, pre-pneumonia as well. These patients are sick patients. Remember that. All of them you need to identify.
Yes, sir.
Yeah, good. And whenever
Yes.
you're seeing this, look at the downward structures also in the liver and the spleen also. When you're doing a scan, just sweep the probe towards the spleen and liver to identify the infarct there. Not in the X-ray, but in the photo.
Yes, sir. So then the patient was sent for routine blood investigations. In view of vegetation at the mitral valve, 3 sets of blood cultures were sent, and also there are sepsis protocol. All cultures were sent. In view of altered centurion, CT brain was done, normal, and ultrasound abdomen was done, normal, as there is a previous history of urosepsis, and 2D echo showed there is a mild LV dysfunction, sir, with EF of 50%, and mitral regurgitation is present, and there is vegetation at mitral valve area measuring 10 mm, sir.
So I
Yes.
think Arif sir, do you want to take
Yeah.
this?
Yeah. Yes, Dr. Suresh, please.
Yes, sir.
So each of them, the one we wanted to ask is there is nothing like a routine investigation. Don't do these words in the exam. There is always a specific investigation. Okay. So what are the things in the blood, the regular parameters? You do a CBC. What do you expect in endocarditis? You expect something like, if it's a 2 chronic one, you expect something like an anemia of chronic disease. If it's an acute one, you can have a normocytic normochromic anemia. You can have a bicytopenia. These are chronic features of the. Here you need to look for the granule in the band shift towards the left side, which will tell you that.
Voice.
I don't know why
Yeah.
I'm trying to do.
Dr. Suresh. Yeah.
Sir.
Yeah. Am I audible?
Yes, sir. Yes, sir.
Yeah. You are talking about these 3 sets of blood culture. Is there any significance of this number of blood cultures?
Yes, sir. If you send the 3 sets of blood cultures, the yield is about 96 to 98%, sir. If we send 4 sets of the 4 sets of blood cultures, the yield is very much more, sir, 99%, like that, sir.
Okay, please.
So what do you mean by a set here? Set means there's an anaerobic and aerobic. Two cultures are sent in the single one. Okay. When you're telling about 3 sets, that means that 3 sets of aerobic and anaerobic.
Yes, sir.
Okay. This is for the students I'm saying, and always try to do it from a different places, non-contiguous sites. Most of the time, 3 sites are very difficult in an emergency or ICU. At least 2 anaerobic and aerobic sets you should send, and from 2 different places. Okay.
Yeah, and also the volume is minimum 10 ml.
Yes,
Yeah.
exactly. The more volume, more yield.
More yield is good. Yeah.
Never give an antibiotic before the culture. Okay.
Yes.
Then.
Yes.
So
No,
the investigation.
I think you skipped this. Go back. Yeah. What is culture negative endocarditis?
So culture negative endocarditis may occur when the patient is already treated with antibiotics previously, or when there are intracellular microorganisms causing infective endocarditis like Auxiliar, Bartonella, and Chlamydia species.
Yes, exactly.
Bartonella and chlamydia species, sir. And
Yes, very good, very good.
yes, sir. Non-candida species.
Mycoplasma, brucella, chlamydia, coxiella. These are usually manifest as a culture negative endocarditis. Here is the setting. The examiner will discuss about the PCR technique, the serology, multiplex PCR. Here it will be very useful for you. Okay? When you have a strong sign of endocarditis, you see a vegetation, but the culture is not showing anything. You need to resort to the PCR technique. Right?
Yes.
Okay.
So what do you think? What is the role of this molecular rapid diagnostic test at this junction? If the blood cultures are negative?
This molecular rapid diagnostics tests are definitely useful, sir, but they should be used in the context of antibiotic stewardship. This one, sir. They showed some mortality benefit, but still studies should be done.
Yeah.
So you've done a CT brain. If the patient is stable, I know that your patient is too sick. You wanted to rule out the major things, but if you have a choice, your patient is stable. Okay, you could have done a MRI, right? Isn't it? When you are
Yes, sir.
in an infective endocarditis, what are the findings which you expect in an MRI brain or a imaging of the brain?
Any embolic infarcts, sir.
Okay. So I will tell you, okay, you can have both the clots as well as the bleeds. Okay.
Yes.
So almost, and this happens in a left-sided endocarditis, not happens in a right-sided endocarditis.
Yeah.
Yes, sir.
And if you do a scan for a MRI scan for a left-sided endocarditis, almost up to 60 to 70% will have some sort of clots in the brain. But only 20% will have a clinical manifestation like a stroke.
Yes, sir.
Okay, and you can always have an associated hemorrhage, and in fact both of them in the brain in the same patient. This becomes important for you when you're deciding the anticoagulation later part when you are operating or doing the surgery. Most of these things come in the watershed area. These are the classical way the brain looks in when you do a scan in a left-sided endocarditis. Okay? So many of the tests with a stroke, then retrospectively you diagnose an infective endocarditis.
Yes.
In an ultrasound abdomen, you are trying to locate for again a septic secondary distal manifestation, like you can have a splenic abscess, you can have a distal abscess in the kidney, that is something, or you can have an infarct. Both of them you are looking in an ultrasound. Okay?
Yes.
Yeah, go ahead.
So the investigations showed the counts were 13,500, and our creatinine was normal, 0.9, and LFTs were normal. So it's side screen converting. So there is a raised procal and raised pro-BNP. INR is not.
So what do you interpret these tests? Just club it and let us know your impression.
So some sepsis is there, sir, with heart failure.
Sepsis with heart failure. So I will interpret in this fashion. Okay. Definitely my counts are not low. It's definitely elevated. The WBC is around 13,500. It's like more, right? We're thinking something about a bacterial infection, or at least at this point. We know the background, you know the past setup, but that is how I
voice break.
Here I will try to look at the band forms and the toxic granules. Okay.
Yes.
So here in the first CBC part, that is how I'll look. This patient is not still in DIC because the platelet seems to be reasonably okay, right? INR is also going on. So then I'll come to the renal function initially we suspected an acute kidney injury in the renal failure. At least now I am reassured that his RFTs are not that bad. If you're talking this is on the first day of when we come to the LFT is not that bad for the sickness of the patient. Procal is elevated. How do you interpret this? Again, you're not thinking about something like a fungal or maybe an atypical organisms. You're again thinking about something nosocomial infections. This patient, but in the past, he had a urosepsis, maybe a gram-negative bug. Now his procal is elevated. So I'm thinking about something covering a gram-negative infections. At this, if I start something, my antibiotics should cover a gram-negative bug. This is how I go. ProBNP is elevated. So definitely something, and you said your LV is also impaired, right? So whatever it is,
Yes.
heart is also getting hit. Not much of a significance for a D-dimer here. For the PTINR and APTT, I think I'll keep it in mind when I'm deciding the anticoagulation. That is how I interpret this. Okay. Yeah.
So coming to the management, in view of infective endocarditis, we have started him on injection ceftriaxone 2 grams IV OD, sir. And as the heart failure features were there, Lasix 20 mg IV TID was kept. And
But why did you start? Why did you start a ceftriaxone when you knew that your procal is 5.8? This patient was already in the hospital 10 days back. He had central lines. He had a urosepsis, isn't it? You're supposed to
yes,
start conventional gram-negative MDR coverage, isn't it? What was the
yes,
logic in starting the ceftriaxone here, which is more of a native wall endocarditis, no?
yes.
Why? Any reason?
In view of native wall endocarditis only, we have started.
No, agree with the native wall part, but this is something with a significant
Patient is progressing to the
hospitalization.
multi-organ failure.
Yes, sir.
And he had previously been hospitalized, na?
Yes, sir.
So here you should search for the previous cultures. You most of the time the same bug will be there. Okay.
Okay.
Okay, good. Yeah,
So Duke's I kept Duke's criteria.
in your patient, what are the criteria which has been satisfied to label him as a infective endocarditis?
So mainly the imaging criteria, sir. In major criteria, the 2D echo has showed some vegetation. And in the minor criteria, the patient has a fever.
It's quite simple, no? Your imaging is positive, which comes as a major criteria.
Yes, sir.
Isn't it? And he already had a fever which has been quite significant. Second one is satisfied. Then what is the other one which is being there? Have you searched for the cutaneous lesions, GNV, Auxiliar, all those?
Yes, sir. We have searched, sir, but not.
Yeah. Any MRI was done for this case?
Later. MRI. Yes. Yes.
Okay. Fair enough. In a clinical setting, I think these things evolve. So yeah, understood. Go ahead. And one small point about the labs part, I think in a urinary tract, in a complete urinary examination, you should look for the glomerular. Okay. Don't
So voice breaking.
I'm very sorry, I don't know. I'm trying. In a examination part, in the complete urine examination, you should look for the glomerulonephritis, like proteinuria,
Yes.
hematuria, things also you should look. And if it is fitting there, or if you have a positive rheumatoid factor, okay, they also comes as immunological manifestations of the carditis, and it can satisfy your Jukes criteria. Okay.
Okay, sir.
Yeah.
Yes. So this is the classification, sir, whether it is a definite or possible. So in our case, it could be a possible one, sir. One major and one minor.
Most of these criteria evolve over a period of time. Just because in the first day all the criteria were not met. If you have a strong suspicions, you need to repeat this criteria again day after that, so on and so forth.
Yes.
Especially when you have a strong suspicion. Okay.
Yes. So these are the SC guidelines to how to diagnose infective endocarditis, sir. What the clinical presentation, blood cultures. After that, we have to define whether it is definite, possible, or rejected. In case of possible, we have to repeat the cultures like that. So. Okay. Can I proceed, sir?
Yeah. I think once you complete this quickly, we'll complete the discussion also. Yeah.
Yes, sir. So after 2 days of admission, the patient developed right side weakness, sir. On examination, pupils were bilateral normal size reacting, vitally stable. Neurology consultation was taken. They advised MRI brain, which suggestive of hemorrhagic infarcts in the left precentral gyrus, left insular cortex, and left frontotemporal upper column, tiny infarcts in the right high parietal region, suggestive of embolic infarcts, sir. So later, in view of prolonged intubation, the patient was subsequently tracheostomy was done, sir. And after over 10 days of time, the patient sensorium was improved, and he was subsequently kept on thermovent, and then decannulation was done, sir.
Okay. So, yeah, good job and on a whole, I think teams that Suresh. Couple of things. Could you have done something to prevent this embolus, this hemorrhagic infarct, that kind of thing in the brain? Because 2 days the patient was there, no? Could we have done something?
Mm-hmm.
You know there's a vegetation, right?
Yes.
Could you have intervened with a surgeon, removed it? Maybe that could have prevented the embolus and the subsequent stroke. Is it a possibility? So,
yes.
Coming to the question, the specific question is, what is the role of surgeon? When do you give surgery?
So the indications of surgery are when there are emergent indications are cardiogenic shock or acute pulmonary edema, and
So both were there here. Both were there here, right?
Yes, acute aortic regurgitation, and emergent indications are like this vegetation blocking the valve, and prosthetic valve dehiscence, valvular perivalvular abscess formation.
So what is the size of the vegetation here, Dr. Suresh?
In our case, 10 mm, sir.
Okay.
So 10 mm with embolic phenomena are more than 30 mm are indications for surgery, sir. Or fungal endocarditis, or prosthetic valve with Staph aureus infection, or indications for surgeries.
Okay. So it always depends again on the events. Okay. For example, as you rightly said, if your vegetation is more than 10 mm, or you already had a history of one embolic episode. Here the problem is we don't know. We have done a CT brain, which is plain CT. We may not have known the previous embolic episode, right? So unfortunately, the patient was too unstable to do an MRI. But any vegetation, usually if it is more than 10 mm, and as I told you, most of them will have almost 70% of the time. By the time you diagnose, they'll have some sort of embolic episode. May not have a clinical manifestation. Okay. So you need to be very clear about the difference between left-sided endocarditis and the right-sided endocarditis. Right-sided endocarditis, you'll tolerate the vegetation up to 20 mm. Only if you have a recurrent embolism and there's if it's not responding to antibiotic, then you'll involve the surgeon. Or if you have a severe TME. Whereas the left-sided vegetation, you'll keep a lesser target, like maybe a 15 mm, a 10 mm, those kind of stuff. Okay, here. And when do you not go for a surgeon? What is the contraindication for surgery? What is the contraindication for surgery? The contraindication is when the patient cannot tolerate the anticoagulation, because these patients, your patient had a stroke, no, massive stroke, that too hemorrhagic one. So these patients, if they can, and obviously they need to be taken on a pump, which requires an anticoagulation. If you can't do that, this is not a condition taken like for the surgery. But if you want to do, when are you going to do? 4 weeks is the usual period where you delay and then you do the surgery. In this kind of complicated situation where you can't anticipate, but surgery is required, then that is the condition. Okay.
Yes.
Yeah. Coming to the anticoagulation part, what are the guidelines?
So anticoagulation, it's a bit controversy, sir. In view of hemorrhagic infarct formation, usually this anticoagulation is not advisable. If needed, mechanical compression devices are indicated. If really anticoagulation is needed, unfractionated heparin can be started, sir, monitoring the APTT values.
Okay, in your patient, is there a role of interventional radiologist? This patient had an in-hospital stroke, right? This is a hemorrhage.
Yes.
Nothing much we can do. But in case if it is an ischemic stroke, would
Yes.
you involve an interventional radiologist? Is your stance same as your regular ischemic stroke and the septic emboli?
No, sir, it is as it is the embolic phenomena, the interventional radiologist can't do much.
No, it actually you can involve it, right? But the problem is it
Okay,
will be too friable, okay, too difficult to do. But if there's a large septic emboli blocking the major arteries, you can still do it, okay? Still those holds good, but there's no role of your systemic anticoagulation in a septic emboli. Okay, the patient will deteriorate much further. Okay, so then what do you want to do with your patient here? Antibiotic is something, I think, do you want to revise it? You want to stick to the ceftriaxone or anything that came in the culture later on?
No, sir, the culture was negative, sir.
Okay, and with the ceftriaxone, your procalcitonin came down.
No, sir.
No, I'm just asking. Coming, I think.
No, Dr. Suresh, is the antibiotic has been revised or escalated?
Yes, sir.
For this case?
Yes, sir. Yes, sir. We have added.
What antibiotic? Then go ahead.
So we have also added this gram-negative coverage, sir, as there is a previous hospitalization. As the patient is also presented was in shock, so we have went for carbapenems.
That would be the one we use. All of us will do the same thing, no? I think that would be the more natural way of doing it. So we'll quickly revise the line of management for the antibiotic management for the infective endocarditis.
Yes.
Shall we ask and you tell, or is it the other way? So because the time is running out.
Yes,
so yeah, ceftriaxone. Usually, you'll say, when are you going to give a ceftriaxone? Ceftriaxone.
Native
Yes, very good. So you usually prefer 2 grams twice a day, not your regular dose of 1 grams. Okay. Usually you'll prefer when your source is either a oral source or a gastrointestinal source, not your urinary source. Whereas in a urinary source, usually you'll prefer an ampicillin sulbactam, because the ampicillin sulbactam has a better enterococcal coverage than the ceftriaxone. Okay.
Yes.
If your native valve endocarditis, you're thinking about a gram-positive organism, and you're thinking about an MSSA. MSSA is the usual one, right? Cefazolin is the better than all the other antibiotics.
Yes.
Whereas if you're thinking about an MSSA, MRSA, what do you do? What do you add?
Vancomycin.
Yes, vancomycin, linezolid, and daptomycin are the usual choices. Vancomycin
Yes.
has a more experience. Okay, but the
Yes.
only problem is vancomycin takes a bit of time, like 1 to 2 days, till to get its own action. Okay.
Yes.
So, what is the role of this one, piperacillin tazobactam? Piperacillin
Yes.
tazobactam you use mostly when you have an IV drug abuser or when you suspect a pseudomonas. These are the settings,
Yes.
especially the right-sided endocarditis. That is the situation where you use a piperacillin tazobactam. Okay.
Yes.
If your patient had a prosthetic valve, does your line of management change? Will you still start a ceftriaxone or will you start with a different one?
For native wall endocarditis, same.
Prosthetic, yeah.
Ceftriaxone.
Prosthetic valve endocarditis, always remember there is an early component and the late component. Okay. Early component occurs less than 3 months. Okay. So where you are going to start a carbapenem or ceftriaxone or piperacillin tazobactam.
Infections, yes. Late component, same as community acquired.
Yeah. Yes, there you need to cover your regular organisms as well as the enterococcus. Okay.
Yes.
If you're thinking of enterococcus, ampicillin sulbactam is a better choice. If you have only ceftriaxone, 2 grams twice a day is a reasonable choice. What is the role
Yes.
of rifampin? When are you going to use this?
Culture negative Bartonella species. Prosthetic valve.
Rifampin should only be used in a foreign body infections, like you have some prosthesis. Okay.
Yes.
And it should be started after proper antibiotic coverage of 3 to 5 days. Only once your bacteremia has been comfortably cleared.
Yes.
It doesn't have an acute action. It only prevents the replication of the bacteria, and you'll have a biofilm, no, on the prosthetic walls. That is where you can. Okay.
Yes.
Okay. And enterococcus, anything specific? How are you going to treat the yeah? I'm just scrolling through each of them. Yeah. No, you should always tell, is it a sensitive one or is it a resistant one? Okay. If it's a susceptible one, your ampicillin ceftriaxone is a reasonable coverage. Okay. Whereas if it is resistant, then you'll add a vancomycin. Okay. And if it is a VRE, what is your choice? Vancomycin resistant enterococcus. Your choice is either a daptomycin plus ampere plus ceftriaxone or linezolid. Okay.
Yes.
Okay. So I think any doubts here? What is HESEC group?
So HESEC group organisms are Haemophilus, aggregative bacter, Cardiobacterium hominis, and Tingella and Echinella.
What is the specialty of them? Why are we discussing here?
Usually, they won't grow in culture.
The new name is Agrigobacter. Okay, it is not HESEC anymore.
Yes.
They are quite slow to grow. What is the treatment here?
Ampicillin. HESEC group.
Your statement is still a ceftriaxone. Okay.
Yes.
And if you cannot give a ceftriaxone, if the patient had an allergy, you can go for a fluoroquinolones. Okay. Okay.
Here is regarding duration of antibiotic also. One question. Some doubt from the audience.
Yes, a native wall endocarditis, 4 weeks duration, sir. Prosthetic wall up to 6 weeks duration, sir.
No, but again, it depends on the organism, no?
Yes, sir.
Yeah.
So if you're talking about a viridans, That is what is native valve is 4 weeks. Okay.
Yes.
If you are talking about an MSSA or MSSA, it is minimum of 6 weeks. Even in enterococcus, minimum of 6 weeks.
Yes, sir.
Then Candida, fungal endocarditis. What is your take?
6 weeks, sir.
No, what do you want to give?
Amphotericin B or echinocandins.
Dose.
Amphotericin B up to 3.5 to 5 grams dose.
It's okay. So yeah, what you said is correct. Usually we'll add a flow cytosine, but in a real practice, these patients are quite hemodynamically unstable. No, they will have a lot of other organ involvement. Usually you'll prefer echinocandins also in a high dose. Okay. And once you completely treat it, you need to keep a prophylaxis also on a long run. You need to suppress it. Okay. So Arif sir, next.
Yeah, the session has gone in a real way, the real examiner and the real student. Because most of the students, when we are starting the case examination, they think they'll prepare for one for particular condition, like particular diagnosis. The examination has gone in a real way because starts from the initiating history as well as examination and go on. Excellent, Dr. Deepak.
Sir, anything? I think please add something, sir. Suresh, what do you want to do? This obviously for the neurological perspective, we're going to do the rehab part and all. One, I'm just quite interested. You showed the ventilator panel. There's a loop there.
You don't, sir, voice breaking.
No,
Yeah,
in the
yeah.
ventilator panel you showed, na? The patient picture.
Sir.
Yeah, what is the loop? Can you interpret it and why 16 PEEP? You said there is no ARDS, no? You have only pulmonary edema. So the point I was trying to tell is the examiner can ask whatever. Okay.
Yes, yes.
Nothing much. It may not be only about IE because you read IE.
Yes, yes, yes.
Okay, sir. So I think we are overshooting the time, sir. As I think senior
Yes.
examiner is Arif, sir. Please add it, sir.
Yes, yes. So we'll go on in a best way, Dr. Deepak. We can go on. We can close if there is any other doubts.
Yes, sir, but
Yeah.
also we have
Yeah.
some question in the chat box.
Yeah, sure with that. We have most of them are been cleared, it seems.
Yeah.
Yes, sir.
Hi, good evening.
Asif,
Deepak,
Hi,
good
hi,
evening.
Asif sir.
It was
Good
an
evening.
excellent class. Hi, Dr. Arif. How are you?
Yes, I'm fine. Thank you.
And Suresh, hi. You have done well done.
Yes, sir.
So,
Thank you, sir.
I think Dr. Gunadhar and Dr. Achilles also be with us.
So I think we'll come in a sequence then.
Yes, yes.
I'll start with the last one. Any role of aspirin in embolic strokes with hemorrhagic infarcts in this case? Okay. Yeah. Actually, there have been studies in these patients, especially the patients where you cannot anticoagulate, antiplatelets there, but the evidence is mounting. Usually, most of the evidence is with a low dose of aspirin, but there's nothing specific here. So you cannot actually quote it in the Excel. Second point is, I would like to ask when we use the echocardiography system management of IE, should the TEE be performed in all patients suspected of a prosthetic valve or intracardiac infarction? No, nothing specific. If you have already diagnosed it, as we discussed, no, TEE will be done when you don't know, when you have a lack of clarity on a TEE, or you want to see, you want to have an exact clarity on the perivalvular complications, or when you want to have, when you have a doubt, is it something prosthetic valve related or is it specific medication, then only you do it. There is nothing like a hard and fast rule that every patient should be subjected to a TEE. Coming to the next one, what is the duration of antimicrobial therapy? This I think has been
Yeah, we have covered it seems.
yes. Culture negative endocarditis also was discussed actually. Okay. Right-sided presentation antibiotic coverage also was discussed. to ask what is the management approach for endocarditis in pregnant women considering a fetal and maternal risk. This is a very interesting question. Most of the line of management would be standard. Okay, nothing major.
Yeah.
Because we are not going to anticoagulate with aggressive measure. There's no role of it. We would be much more quicker in acting, and the surgeon should be involved much more fastly here, because the complications will be detrimental. Antibiotic, as you all know, you'll be choosing something which is safe for the pregnant women. Nothing specific here. What if the previous UTI was sensitive to ceftriaxone? Yeah, obviously, but at least in our real practice, we have never, at least in my last 7-8 years, I've never seen a UTI which is I wouldn't bet on ceftriaxone and you have a UTI. How high is the BNP will rise in sepsis? There is no hard and fast rule. It can go up to any level, especially when you have a septic cardiomyopathy. But usually, double digits of thousands are the primary disease. Like you can go up to single digits of thousand, like 3,000, 4,000, 5,000, which can come in a sepsis cardiomyopathy. But if it is something go up to 11,000, 20,000, 30,000, usually you think about a primary cardiomyopathy. LASIX was started for this patient whose BP is low. I'm not sure. Suresh should answer it. But, usually, if that is the case, usually you stabilize the map. You want to wean off the patient, you will keep a LASIX incision than the bolus process. Want to ask, is there a vegetation? I think the rest of the questions, I think, was already answered. Yeah. One question was, do you think is it better to start ultrafiltration in this patient or wait 24 hours or to see up 24 hours? I think this was question was asked before the case completely was done. I think there's no role of it.
So great, Deepak. Thank you very much for this session. You gave a lot of information. And basically, some of the surgeons should also attend this CBTS cardiovascular should also attend. Because many a times these surgical colleagues are very reluctant to operate. If the patient has infective endocarditis, the surgeons will also keep saying that the vegetation is the valve is going to be fragile, the tissue will be fragile, it will be very difficult to feed that valve also, there is a risk of cardioembolic stroke. But in a desperate situation where you have a thrombus load, which vegetation load which is higher and it is more than 10 millimeters, it is worthwhile doing valve replacements in patients with the infective endocarditis. Of course, they should receive appropriate antibiotics, and the surgical procedure is the treatment of choice. And most of the times we end up having strokes. Okay, invariably these patients will have a stroke, in due course of time, is not handled surgically. I think that message is very important. And really, thank you very much for this session. It was so informative, and I think all the students will also be benefited. This session is recorded and will be available later on. Dr. Asif.
Yeah, we will send the link in the group. So WhatsApp group. So everybody will get this video, and it is always something different when Deepak taking class. Always, it's a opportunity to learn from him.
Yeah.
And Arif is a great examiner.
Because I acted as moderator, not examiner, because I have left to the Dr. Deepak.
Yeah.
But I think well done, Dr. Suresh. Also, you've been very calm, composed.
Yes.
That's a good sign
like
of
a real student.
Thank you.
Yeah. I think this class will benefited our student who are doing the DRNB and who are preparing for DM, DRNB and the EDIC examination. So it's great help for them. Thank you. Thank you all.
Yeah, thank you all.
See you next time.
And one small announcement in this group that we are planning to do a mock exam for DRNB student who is giving this year exam. So 17, 18, 19 January is the theory exam, and we are planning to do our mock rehearsal exam on 8 and 9 February, Saturday and Sunday. So Achilles is hosting this venue. So Achilles, we will made a flyer for you, and we will circulate. And Deepak, if you have any student, just information share kar dijiyega. And if you have a time, you can spare, and I will request Arif also. If you have a time, you can spare 2 days in Mumbai, then we'll have a great session.
Yes.
Gunadhar is
Yeah.
there, Achilles is there.
This exam we will target like the long cases and even the short cases, and the students will also have the opportunity to go through the workstations, the different workstations that they have to go through in the final exam. This exam will give them extra confidence as well, because most of the times what we see, the students come for the exam, and they, even though they may be prepared, but they are not confident, and what is expected from the students is the examiner doesn't get that, and then he has to ask leading questions, so that can be avoided, and the students will be more confident when they give mock exam and they go for final exam.
Thank you. Thank you all. Thank you, Sana, for wonderful coordination.
Yes, so thank you. Well, thank you everyone present here. Thank you our organizers too, our moderators and our presenter too. We'll meet soon. Thank you. We'll end the session here.